presentations on the impact of COVID on NTD programs across 7 diseases. And then, so we'll do the presentations and then we'll have a Q&A at the end. So if you want to submit questions, please do it through the Q&A at the bottom of the screen, and we'll monitor those. And it is possible that speakers will answer some of those during presentations. So I'll hand over to Tamara now for a brief introduction.
Thank you. Hope you can see me okay. So I'm Tamar Ghosh, Chief Exec of the Royal Society of Tropical Medicine and Hygiene, and we're really delighted to be partnering on this amazing activity. As we know, lots of diseases have been affected by COVID-19 this year, and it's great to have this project showing the modelling of that and some of the evidence behind what the impact has been. So as I said, we're very pleased to be part of this, so thank you all for joining. This is the first, as Andrea mentioned, of our webinars. There may be others. We will see how things go and have your input to that. And we'll also be launching a special issue of our journal in the coming weeks to try and bring again some of this, the research findings together. And we're just really excited to be part of it and see if we could help in any other ways in really showcasing the great work of the Modelling Consortium. That's what I was going to say. Enjoy the presentations. Thank you.
Thank you, Tamar. So my name is Deirdre Hollingsworth. I'm an infectious disease modeller at the University of Oxford, and I'm a member of the NTD Modelling Consortium, and we are also very delighted to have this opportunity to work with the Royal Society of Tropical Medicine and Hygiene. And as Tamar said, we're working on a special issue of Transactions of the Royal Society of Tropical Medicine and Hygiene, which should be coming out soon. And we've really valued the interactions with the editorial team and the reviewers. So if you're one of the reviewers, anonymous reviewers, thank you very much for your time. So from our point of view, this is an opportunity to get into a little bit more detail about some of the diseases that we've been working on and providing some of these analyses of the impact of interruptions to NTD programs. Previously, so there's been some general presentations at the WHO webinars, but this is an opportunity to get a bit more detail from the people who've really been doing the work, and so we're delighted to have some of our early career researchers presenting today. So do ask questions, and we will address them at the end of the session just to make sure we get through all of the diseases. But this is an opportunity to talk to the people who've done the work, find out a bit more about what we've done, and we're happy to start a conversation today. So thank you very much, and I'll hand over back to you, Andrea.
Thank you, Deirdre. So let's get started with our presentations. Joaquin, so thank you very much. Our first one is from Miriam from Warwick, and she's going to present on jihad. So Miriam, please ask Joaquin to change slide when you want to.
Okay, thank you. I don't know why I can have the video, sorry, but somehow I was interrupted, but I had to come back, so I lost the video. Yes, yeah, thank you for organizing that and also for giving me this opportunity. We actually studied the impact of COVID-19 interruptions on jihad or sleeping sickness with the help of modeling approaches. Next slide, please. Okay, thank you. Yeah, we in this work we use 2 independent stochastic models. Model S, which is the one developed in Swiss TPH group, and model W developed in the Warwick team, and we studied the same problem, and we studied the disease dynamics and the underlying new infections for jihad. And we particularly, in this study, we particularly look at 2 different health zones, Mosango and Bogota, which are at different levels of risk. So they are considered as moderate risk, but Bogota shows higher infection, and that's why we call it high risk here. Yeah, there are 2 health zones in DRC that we are interested in this work. We know that in DRC, active screening has been interrupted since April because of the pandemic. However, we are not completely sure how much the passive surveillance is influenced. Therefore, we consider some general interruption scenarios and we compare them with each other. In this work, we have, of course, a baseline where we continue active screening with an average mean value over time, and we don't interrupt anything. Both active and passive screenings are fully optional, fully operational. And then we introduce interruption scenarios which can end till the end of 2020 or 2021. We consider cases where only active screening is interrupted or passive screening is interrupted as well, fully or partially. So we have, in fact, 6 extra scenarios for interruptions, and then we consider mitigation when active screening would be set to the maximum level after the interruptions. Oh, sorry, next slide, please. Okay, this is one example of the dynamics for Mosango and model W. It's just to describe how we actually plot the dynamics of the system, the dynamics of the infection. Here, new transmissions and reported cases are plotted as a function of time, and the baseline when there is no interruption is like shown with a black solid line, and then we can see that all the colors which represent different scenarios and deviate from this baseline. We also showed mitigation scenarios with dashed line. Next slide, please. So that was just one example, but we have all the infection dynamics for both Bogota and Mosango, and also for model S and model W here plotted. Here I show all of the plots. And of course, we see that during interruptions, new transmissions increase, reported cases decrease, and death increase, which can actually continue to be interrupted after interruptions stop after 2020 or 2021. We see that if interruptions are only in active screening, there is not much impact on just the infection dynamics. It's actually very difficult to go into details of all these plots now, but to get some conclusions, can we go to the next slide, please? Yeah, actually we can look at the elimination goals, the probability of elimination, which is plotted here as a function of time for 2 different health zones, Bogota in the first row, Mosango the second row, model S the first column, and model W the second column. We have the same colors for different scenarios, actually these results shows that interruptions can push back the elimination by maximum of 3 years as predicted with our models, and of course we see longer delays when there are like longer interruptions and both activities or both active and passive activities are fully interrupted. In these results, actually, our results predict that Bogota is not very optimistic in reaching elimination by 2030. So we have like something like 30% of probability of reaching EOT for Bogota. Of course, it would decrease when interruptions are introduced, but we believe with current medical strategies, it's probably better to introduce something extra to somehow increase the probabilities of elimination. On the other side, in Mosango, our models predict that it's and I mean it's we can reach probability, but we can reach elimination by probability of more than 70% by 2030 in both models, and it's quite optimistic. However, it will be less probable if interruptions are introduced. But it won't go in I mean, such predictions, it won't go below 50% still. And the mitigation scenarios show that increasing active screening after interruptions actually could help and could bring forward the time to elimination, even when we compare it to to the baseline when nothing is interrupted. So I hope I could give you a brief summary of the latest manuscript that you can find here, the reference in medRxiv at the moment. Thank you for your attention.
Yes, good afternoon, everyone. Shall I go straight through with the next?
Yes, please, Epka. Just a reminder that please submit your questions through the Q&A box. Go ahead, Epka.
Great. So in March 2020, India declared a nationwide lockdown to control the spread of COVID-19. And as a result, control efforts against visceral leishmaniasis, or VL, were also interrupted. For these analyses that I'll present here, we've used our established age-structured deterministic VL transmission model, which was developed at Erasmus MC. Next slide. Yeah, thanks. So the default control efforts to achieve elimination of VL as a public health problem, which is the target, consist first of a 5-year attack phase, which is then followed by a consolidation phase. The target is defined as being below an incidence of 1 VL case per 10,000 people per year for 3 consecutive years. Here we see projected trends for 11 pre-control endemicities. So that's on the y-axis under the default strategy. So a steep decline under the attack phase, and then you'll see the consolidation phase. The black dots that you see is where the target is achieved. Next slide, please. However, with the interruptions, they could take place at different moments in time. So if we look at here at a scenario, this is all 9 per 10,000 VL cases per year pre-control. We see that if the interruption would take place during the attack phase, 3 years after the start of the program, which you can see in the top panel, a 1-year interruption of the program would lead to a delay of about 3 years to achieving the target, and a 2-year interruption could lead to a delay of about 5.5 years. If we then, if the interruption would take place about 6 years after the start of the program, let's say early in the consolidation phase, the achievement of the target would be lost. So this is shown in the middle panel. Here the target was already achieved before the interruption, but due to the interruption of the program, the target was lost. Both for the 1-year and the 2-year interruption scenarios. And it would take 5 or even 7 years respectively for the target to be achieved again, counting from the start of that interruption. So if the interruption would take place 13 years after the start of the program, so well into the consolidation phase, as you can see in the bottom panel, the timing of the achievement of the target would not be affected. It was already achieved, and it is not affected by an interruption. So you can see that the timing at which the interruption takes place, so for a setting and where they are on their road to elimination, highly matters. And we also simulated the impact of a mitigation strategy to counter the damage done by the interruption, which is, we assume this to be an implementation of an attack phase, either at the end of the attack phase or during the consolidation, depending on where the interruption took place. And if the target is delayed, as you could see in the top panel, a mitigation strategy could really reduce this delay by nearly a year, if there would be a 1-year interruption, or nearly 2 years would there be a 2-year interruption. In a similar setting, where the target is lost in the middle panel, a mitigation strategy could reduce the delay by about half a year or 1 year respectively. And as you can imagine in the bottom panel, the mitigation strategy would have no additional impact. Sorry, now then please the next slide. Yeah. No, sorry, we were still on the first slide. Go back to the blue one, please. Yeah, thank you. So what we see here is that we see on the y-axis that there we simulated 11 different pre-control endemicity levels, and on the x-axis for 16 different times stages of the control program. And here we see that in all the underlying simulations that we assume that the interruption and mitigation scenarios last 1 year. In the left panel, the difference in years to achieving the target can range from 0 to more than 7 years. In the middle panel, the mitigation strategy shows that it can reduce the delay to the target by about 9 months on average. And in the right panel, we can see that even with a mitigation strategy, there will still be delays to the target compared to the counterfactual without an interruption to the program. Next slide, please. So what we see here is that we didn't only, so previously we focused on achieving the targets and maybe bringing, and what is the delay to achieving the targets, but we thought it was also very important to focus on the interruption of the program sorry about that, on cumulative incidence. So besides the potential delays to achieving the targets, we here looked at that, we found that not only the high endemic areas, but all settings are affected. All will see an increase in incidence due to such an interruption. I think due to time, we can go to the next and final slide, where I bring both topics together. So as we've seen, the delays can estimate up to, can cause a delay up to 7 years. This is for a 1 year interruption. Highly endemic settings were definitely affected more, about 5 to 8 years. And for settings that a mitigation strategy is most relevant is definitely in these highly endemic settings, 5 to 8 years into the program. However, when looking at the cumulative incidence, all the settings expect an increase in number of cases. And what we found, this is very interesting, is that the impact on cumulative incidence is highly affected by the duration of the interruption. So I think it's important that besides implementing mitigation strategies to reduce the delay to the target, it's also important to try and keep the duration of the interruption as short as possible to prevent new individuals from becoming infected with VL. So I think I'll hand over here to the next disease, and I look forward to answering questions at the end.
Okay, now it's my turn then to start. Well, thanks. Thank you for having me here. So I'm going to talk now about the modeling that we did for lymphatic psoriasis, for LF. So without going too much in detail about the disease itself, just straight into the scenarios that we considered. So we had three LF transmission models that we work with in the consortium, epithelial, lymphocyte, and transfield. And we're particularly interested in two epidemiological settings. One is with anopheles-dominated transmission, which is treated with mostly with ivermectin and albendazole and represents most of Africa. And then Culex-dominated transmission, which is treated annually with DC and albendazole, and that's generally representative of an Indian subcontinent setting. So I wanted to explore the current interventions and three mitigation strategies, which are also commonly used for acceleration. So either having additional rounds, so moving from annual treatment to biannual treatment, increasing the coverage. So the coverage is typically 65%, so increasing it to 80%, or changing the drugs to IDA where appropriate. And IDA is the triple drug, so it's DAC, ivermectin, and albendazole, but that's not, it cannot be used in all settings, so only in some of the settings is appropriate. So on the right-hand side, just an illustration of how these scenarios look like. So in a no interruption, these are counterfactual scenarios. So we're treating every year with a single round, and we are achieving a 65% coverage. In the case of a disruption, in this particular example, we're looking at a 1-year disruption where we don't do mitigation. So we miss the 2020 treatment, but then, we can continue resuming 2021 normally. And then further below, just some examples of some of these mitigation strategies. So either with extra rounds, can be 1 extra round or more, high coverage rounds, again, increasing the coverage. It can be for a few rounds or unlimited, and similar with switching to the triple drug. Now the baseline we considered here is programs that started in 2018, which means that the disruption happened in the year 3 of the program, which is in 2020. So basically what happens if we don't do anything? So here is just a diagram to show a little bit kind of the dynamics of the model. So the black line is what we would have expected to happen in terms of the mycofilarial prevalence decreasing over time with annual rounds of treatment. Now, if there is a 1-year delay, which is marked there, so if we don't do any mitigation, which is the orange line, that means that we essentially takes a bit longer to reach the goal, but eventually would get there. And in this example here, we're starting with a baseline around 15% MF prevalence. And you can see now that the goal is around 2030, but it might be a little bit after 2030. So potentially missing the 2030 target, which is this 1% MF threshold, which is the dashed horizontal line. If we have a mitigation strategy, for example, here I'm just showing the 80% annual MDA catch-up strategy. So that's the yellow line. So we can accelerate after the 1-year gap, we can accelerate. So we decrease faster. And actually what we see is that after a few years, we caught up to the progress that we would have made in the no disruption scenario, which is the black line, right? So basically catching up to that 1-year delay that we had. And the interesting thing is that also, if this is maintained beyond catching up, you can see that it actually reaches that 1% threshold faster than the original black line to begin with, right? So it provides opportunity to also increasing accelerating the progress to the 2030 goal. So here's some results of the simulations. I don't want to go through the graphs necessarily in detail, but essentially across a range of prevalence, if we have a 1-year delay in the program, so we miss 1 year of treatment, we get essentially a 1-year delay to reach the goal. And similarly, and that's the orange lines here in the top diagrams. And if we have a 2-year gap in our program, that's the yellow one. So we see on average also something just under a 2-year delay. And again, this is on average. In the bottom plots, we can see just how what is the proportion of locations, in our case, is simulations that we think are going to miss the goal. And obviously, if we have some delays, so we have some gaps in the program and we don't mitigate, you can see that those probabilities of missing the 2030 goal increase by a bit. So just to summarize, so delay in reaching the 2030 goal is similar to the gap in treatment. And obviously, you're more likely to miss the 2030 goals if you don't do any kind of mitigation. So, okay, well then how long do we need to mitigate for then? So actually, and these are the examples, again, left-hand side is Anopheles and right-hand side is Culex, and our 3 mitigation strategies. So the orange one is the 80% coverage, the red one is biannual rounds, and the yellow one, which is we only used it in the Culex setting, it's deploying IDA, and the y-axis was just illustrating the number of years needed for this catch-up. So as you can see here that it only takes about a few years, 2-3 years in most cases, to actually catch up, which means that mitigation is feasible in a few years and we don't necessarily need to run it for a long time. And then the last question is, well, how, if we maintain these mitigation strategies, what is that giving us, right? And so here, this is for the Culex scenario, but we're showing our baseline prevalence on the x-axis and the estimated year to reach that 1% MF threshold. 2030 is a horizontal dashed line. So basically, we want locations to reach 1% before 2030. And as you can see in these figures, that it's independently of which mitigation strategy you use. If you actually maintain it for if you are able to maintain it throughout until reaching 1% MF, you can essentially accelerate and ensure that you are reaching the goal by 2030, even in areas that have a fairly high baseline prevalence in 2014. And just to summarize here, so lymphatic has this target of elimination of the public health problem for 2030, and the modeling results suggest that there is a big impact with less than 10% prevalence. You expect to reach the goal, but that 1 year delay in the 15 to 20 range of prevalence, it'll be about a 1 year delay in the program. So there's a number of catch-up strategies that can be used, and most settings, we're seeing on average a 1 year delay when we have a 1 year gap. So it's really the areas that have a high baseline prevalence that are most at risk of not achieving the 2030 goal, particularly if we don't do any mitigation. Just highlighting again, this was a group effort, so the different modeling teams, and we have the preprint on medRxiv with the title is there, and obviously thanking our funders, the Bill and Melinda Gates Foundation. With that, I'll pass it on to the next speaker.
Thanks, Joaquin. We can go to the next slide. Okay, so when we started this work on the impact of COVID on onchocerciasis transmission back in March, we initially focused on annual MDA programs. So what would happen if you missed 1 or 2 years of MDA in an annual MDA program? And we found that the areas with shorter treatment histories or higher baseline endemicity, so higher baseline microfilarial prevalence, would be most sensitive to missed rounds of MDA, so that's 1 or 2 years. If 2 years of MDA were missed, the best mitigation strategy for this was to implement 2 years of biannual remedial MDA when treatment restarted, rather than increasing coverage. And we found that remedial biannual was much more effective at sort of regaining the elimination probabilities you would expect in the absence of an interruption, and also to reduce microfilarial prevalence in the shorter term. And this is included in a current preprint on medRxiv. Some other things we've been doing more recently that are also included in that preprint are looking at the age profiles of infection. So we're asking, are some age groups going to be disproportionately impacted by missed rounds of MDA? And the reason this is important is that if very young children have high MF burdens, microfilarial burdens, this can lead to disease complications later in life. And here I'll also describe some microfilarial prevalence trends in the context of programs that have already been interrupted by Ebola, and also pre-existing biannual programs, like how sensitive would they be to an interruption. And so in this presentation, I'm not going to talk about any remedial strategies. These can be found in the preprint. And I'm assuming that MDA rounds are entirely missed, not delayed. And there are model predictions from EpiOnco-IBM, which has been developed at Imperial College, and also ONCHOSIM, which is developed at Erasmus MC. And I'll say, I haven't put this anywhere, but this is done with the team at Imperial and at Erasmus. And we've also collaborated with Adrian Hopkins, Louise Hamill, and Phil Downs, the latter two who are working at Site Savers. Next slide, please. So this is quite an extreme scenario. This is a recent program that would have started in 2017, and it's a high baseline scenario, which is a 70% microfilarial prevalence. And this is these are age profiles, and so you've got 2 for EpiOnco and 2 for ONCHOSIM. And this is microfilarial intensity per skin snip. And the different lines represent age profiles at different points in time. And we've divided them into males and females. Males are the solid, females are the dashed lines. And for each model, we have no interruption in 2020 and 2021. And then we have a 2-year interruption. So 2 rounds are missed. So this would be a pre-existing annual program, but with 2 years missed in 2 of the panels. And what we can see from both models is that there are increases in microfilarial intensity. So that's comparing the first and the second, and then the third and the fourth of the 2 different models. But what's interesting is that in ONCHOSIM, you see an increase in older individuals, Whereas in Epi-Onco IBM, you get increases in not only older individuals, but also younger individuals. And so this could be important because if younger individuals have higher burdens, there might be some increased risk of other of related diseases, epilepsy, for example, although we don't explicitly model these, we're just looking at the MF burdens. And the reason the models give these different profiles is the assumed patterns of age-dependent exposure. And given the data, both models make valid assumptions about these age-dependent patterns, but there is uncertainty and there's likely to be geographical variation. So this could be an important consideration if rounds are going to be entirely missed. Next slide, please. So now we're moving on to a different scenario, and we're looking at microfilarial prevalence trends through time. And so in 2014, in West Africa, for example, Liberia, a round of MDA was missed due to the Ebola outbreaks. And in 2015, there was very low coverage. So that's what we're trying to capture here. And so we've got, again, the two models, Epi-Onco on the left, ONCHOSIM on the right, 60% baseline prevalence, the top two panels, and 70 for the bottom two panels. And so a year missed due to Ebola, but no year missed due to COVID is represented by the gray lines. And then the black lines, in addition to a year of MDA missed due to Ebola, have also got a year missed due to COVID. And so what we see is that if you have a higher baseline setting, so that here is 70% versus 60%, you get more pronounced bounce back, given this year missed due to COVID of MDA. And you also see a difference between the two models. And this is due to parametric assumptions regarding processes regulating the establishment of adult worms. And given the scarcity of data on these processes, both models make valid assumptions. So you can really consider the predictions from the two models as representing the parametric uncertainty in these dynamics. Okay, next slide, please. And so now we're moving to a different scenario. This is a pre-existing biannual program. And this was motivated by what's been observed historically in Uganda, particularly the Madi Mid-North focus. And there, due to civil unrest, there was very low coverage from 94 to 2012 at annual treatment. And then at 2012, biannual began. As you can see, that sudden drop is indicated by the two first arrows in the two panels. And so here I've shown the mean model dynamics, which is the green line. So if you did many runs of each model and you took the mean, that's what you would get. And the black lines represent individual runs. And so these represent some of the stochastic uncertainty associated with the model prediction. So you could be anywhere around where the black lines are or on the green line. And what we see in terms of the dynamics is that by the time you get to sort of 2018, the prevalence is already quite low. And so really the outlook for pre-existing biannual programs is quite optimistic. So you can see that when you miss a round, you don't get that much pronounced bounce back, a bit more in Epi-Onco, but not so much. And by 2030, the prevalence remains quite low. So it's quite optimistic for the biannual programs. And so, as I said, there are other modeling done in the upcoming preprint related to annual programs and remedial strategies. That's it. Thank you.
So hi, everyone. In this talk, I'll present some results on the impact of COVID interruption on schistosomiasis. Next slide, please. So the 2030 goal for schistosomiasis is elimination as a public health problem, which is achieved when the heavy intensity prevalence in school-age children reduces to less than 1%. So in this work, we use a mathematical model of parasite transmission and control by MDA to estimate the impact of delaying MDA on achieving the elimination goal. We consider a range of transmission settings prior to MDA and investigate the impact of missing one round of treatment. We also use two age intensity profiles corresponding to low and high adult burden of infection to determine if this would have an impact on missing MDA. So the MDA is implemented at a 75% coverage level of school-age children only. We then missed one round of MDA, either early or late into the program. And after a missed MDA round, we considered three mitigation strategies. The first one is returning with 75% coverage level of school-age children only. The second one is returning with annual 85% coverage level of SAC only. And the third mitigation strategy is returning with 1 year community-wide coverage, followed by 75% coverage of school-age children only. Next slide, please. So for all our scenarios, we determine the time taken to achieve the elimination goal. So in this slide, we present results for Schistosoma mansoni, and in the table, we have the delay in achieving the goal for each mitigation strategy. So we find that in moderate transmission settings, missing the second round of MDA requires up to 1 additional year of intervention to achieve the goal. And this is regardless of the burden of infection in adults and mitigation strategy. We should note here that in some lower moderate transmission settings, for example, SAC prevalence just above 10%, with 75% coverage, the elimination goal is achieved after 1 round of MDA. So there is no delay to the goal when the second MDA is missed. Now, in high transmission settings, the outcome depends on the burden of infection in adults and the baseline prevalence. So for low adult burden of infection, missing the second round of MDA delays the goal by up to 2 years. For high adult burden of infection, we might not achieve the elimination as a public health problem goal, and this is regardless of the mitigation strategy, as we can see from the figure in this slide. This is because MDA of school-age children only is having a small impact on reducing transmission. Now, in these settings, to achieve this goal within a shorter time frame, higher coverage of school-age children and adults would be needed. Next slide, please. So in this slide, we have results for haematobium, and we find that in moderate transmission settings, missing the second round of MDA requires up to 1 additional year to achieve the goal. However, missing the 6th round of MDA does not have any effect on the goal because it has been achieved prior to the missed MDA. Now, for high transmission settings, it can take from 2 to 9 years to achieve the goal. For scenarios where it takes 2 years to achieve the elimination goal, missing the second round of MDA will require 1 additional year of intervention, regardless of the mitigation strategy. We also expect a 1 year delay for scenarios where it takes longer than 2 years to achieve the goal. However, increasing the coverage level to 85% of school-age children or having 1 round of community-wide treatment does not require the additional year. Next slide, please. So to conclude, for mansoni, we found that postponing MDA for 1 year can delay the elimination goal by up to 2 years. An increase in school-age children coverage or a whole community round after programs restart could help accelerate progress towards elimination by reducing the delay to target by up to 1 year. We also find that the greatest impact to be in high transmission settings. Now for haematobium, postponing MDA for 1 year can delay the goal by up to 1 year. Annual 75% school-age children only treatment is sufficient for achieving elimination as a public health problem by 2030. Now for both mansoni and haematobium, we find that missing MDA further into the program has a lower impact on achieving the goal than postponing MDA early into the program. And if you are interested in more detailed results, these are included in the medRxiv preprint. Thank you, and I'll pass it on to the next speaker.
Thank you for the floor, and good afternoon to all of you. I will introduce with this talk, I will present the results of modeling the impact of COVID-19 interruption on the control of soil-transmitted ailments. Next slide, please. Okay, to investigate this impact, we outlined some research questions as: will the programs catch up with the progress after the interruption? Will the achievement of the WHO 2030 target be delayed? And will the probability to reach the target be impacted? And at the end, we wondered if suitable strategies could be used to mitigate the impact. To address these questions, we used 2 stochastic individual-based models independently developed at the Erasmus MC and Imperial College London to simulate the impact of interrupting PC. And we simulated the scenarios that are summarized in the scheme on the right. So we simulated several durations of interruption, 6, 12, and 18 months in 2 different endemicity settings, moderate and high, evaluated at pre-control, where the recommended guidelines are different. So annual PC in the moderate setting and semi-annual PC in the high setting. At the end, we also simulated 2 scenarios where mitigation strategies are implemented when programs restart, such as semi-annual PC or a single year of community-wide PC and then going back to target preschool age children and school age children. Next slide, please. The figures included in the presentation are relate to the moderate endemicity setting. What happens if we restart programs without any mitigation? Control programs will catch up by 2030, and we mean that the prevalence of moderate and the intensity of infection will reach the same value that would have been observed in absence of interruption. The horizontal dashed line represents the WHO goal for soil-transmitted elements set for the 2030. However, the interruption will introduce a catch-up time that is limited to 1 to 3 years in the moderate setting and 1 to 5 years in the high setting. What is interesting to notice is that the 18-month interruption, so the yellow line, does not increase the catch-up time with respect to the 12-month interruption, so the red line. And this is due to the extra round scheduled on 1.5 years after the interruption. None of the different durations of interruption have a strong impact on the probability to reach the target. That, however, can be delayed to a maximum of 2.5 years. Next slide, please. Thank you. What happens if we resume programs after 1 year, but with mitigation strategies? The impact of mitigation strategies in terms of catch-up. So in terms of catch-up, they do not extremely reduce the catch-up with respect of resuming programs without mitigations. And for example, in high endemicity settings that are not likely to reach the target even without interruptions, the mitigation are beneficial on the catch-up time only in the case of trickeries, but they are essential to enhance the probability to reach the target and to speed up the progress. So they could be crucial in those settings where the 2030 goal is far away under normal circumstances. And both the mitigation strategies can accelerate the target achievement. This means that even a single year of community-wide PC is sufficient to compensate for the year missed. Next slide, please. To conclude, I would like to reply to the research question we outlined at the beginning. So yes, control programs will always catch up with the progress by 2030, even without mitigation strategies. However, it will be always advantageous to recover the last round miss as soon as possible to minimize the catch-up time and so to minimize the impact on morbidity. The 2030 goal for the 2030 targets can be delayed to a maximum of 2.5 years. But none of the different durations of interruption have a strong impact on the probability, on the chance to reach the target. The implementation of mitigation strategies are essential to enhance progress, so they could be crucial to in those settings that where it's not feasible to reach the target. They could be crucial to turn the interruption into an opportunity to speed up the progress. And I will conclude here and thank you for the opportunity. I leave the floor to the next speaker.
Thank you, Veronica. So I'm presenting the trachoma work, which was really done by Anna Borlase, who's unfortunately not able to be with us at this particular time. So the trachoma work was a joint piece of work between the team at Oxford and the team at UCSF. Next slide, please. So similar to previous presentations, we have a baseline scenario in which the grey image there, MDA is delivered every year, and we think about missing 1 year of MDA in the blue and the red scenarios. In the blue, you just continue as if there was no break. In the red, you deliver an extra round in 2021. And in the pink, you deliver that extra round only to the children. And in trachoma, the children are believed to be the major drivers of transmission of the bacteria. Next slide, please. So here we have two plots. Now for trachoma, the targets are around the disease. So TF, this inflammation in the eyes, but that is a consequence of underlying transmission of infection. So on the left here, we have prevalence of infection, and on the right here, we have the prevalence of TF. And as you can see, the black line is if treatments continued as normal, and the blue line, if you miss a round, you get behind where you would have been if that round had not been missed. So there's that extra increase in infection in 2020 that takes a while to come down. And in terms of disease, we see this increase in disease over that missed year. Thank you. Next slide. So now, what if we deliver 2 rounds in 2021? Well, we start to catch up pretty quickly. And so that extra round seems to get you back on track in terms of infection on the left plot. But on the right, that disease takes longer to filter out of the population because it hangs around a lot longer than the infection. The infection times are quite short. And so there is this accrued morbidity, even if you come back really strongly in 2021 with an additional round. I should say at this point, this is not the same for all prevalence settings. Obviously, if you're in a lower prevalence setting, these numbers will be smaller. Thank you. Next slide. Now, if you target only the children in that second round, because of the dynamics of trachoma, where the transmission is really driven by the children, we actually see a very similar path to if we deliver a whole community round as the extra round in 2021. Thank you. You can go on to the next slide. So that shows the results really for most settings which are on track to achieve the target, which is elimination as a public health problem. However, there are a number of areas where trachoma programs have been running for many years, and unfortunately, they don't seem to be on track for achieving the 2030 goals of elimination as a public health problem. And on the left and right here are some plots over time of the prevalence of TF, so that's the disease associated with trachoma, up to 2020, they're all saying the same thing. So this is simulating an area where despite giving MDA every year, there's just ongoing levels of infection in the population. Then you miss a round and you see this big increase in that disease in these populations because these transmission rates are very high. And then when you come back, just doing an extra round is not going to be good enough for these places. So what we simulated was doing 3 or 4 rounds in the following years, some of which were in children. And I'm not going to go into the details of the particular scenarios, but here we can see if you give those extra rounds of treatment, you move from being an area which not only was a problem and has a big problem as a consequence of the missed round, to an area which actually maybe elimination as a public health problem might be possible. And there's been a lot of discussion around these results. Thank you. Next slide. And this is just another way of approaching the problem. This was led by the UCSF group. If we think about the reproduction number, which before this year would have been more difficult to talk about, but certainly in the UK, the coverage of the reproduction number has been very high. That's the number of onward transmissions per person. And on the y-axis, we have the programmed delay. So how long is this missed round? In areas where the reproduction number is low, you can tolerate these kind of dark blue areas. You can tolerate even maybe a 2-year delay without the program being too severely affected. But as we move into the red areas where there's a lot of transmission, then any delay just leads to a large increase in morbidity. Thank you. I think that might be the last slide. Is that right?
Yes, that's right. Thank you.
Thank you very much.
So yeah, so we reached the end of our presentations. So you've noticed that I've promote all of the attendees to panelists just to make a more interactive Q&A. So if you wish to ask questions, please unmute yourself and ask for questions. We only have a question in the Q&A box from Che Achungo. I don't know if you want to ask the question.
Shay, did you want to ask your question verbally? If you unmute yourself. Or perhaps if that's not possible, maybe Jonathan, you mentioned unrest in your presentation on Onco. Did you want to talk a little bit more about that?
Well, that was more historically up
Yeah.
to 2012. So yeah, so to account for that, we reduced the assumed therapeutic coverage of the MDA up to that point. So we typically assume it's about 65%, but there we assumed it was 25%. And that's how we accounted for that in the model predictions.
Thank you. Does anybody else want to talk about extended periods of disruption to programs or evidence from past disruptions to NTD programs?
We also show that it's the relation is not linear. So if interruptions stay for a longer time, it can actually have very severe effects. For example, 3 years may be like much worse than 2 years.
Mm-hmm. Yeah, thank you. Jay,
Yeah,
do you
that's the same for VL. Oh, sorry, just to quickly add that for visceral leishmaniasis, that's the same. You see that with just a short extension of that interruption, you already have quite a big impact on the number of cases that keep increasing. So yeah, keeping that interruption period as short as possible, of course, is crucial, but I'm not sure if that answers the question with what can we do to catch up with the rest of the world.
Agreed. Jay, are you able to unmute? Do you want to try again and expand on your question? No, okay. Andrea, I'll hand back to you.
It's really hand back to the attendees because for questions, really, just, please unmute yourself and ask the questions to the speakers.
Hi, this is Fiona Fleming from SCI Foundation. I missed the first presentation, so sorry about that. But I would, and sorry if this has already been raised, but I would like to know if there's been any follow-ups from the work that you've collectively, the excellent work that you've collectively done on modelling the impact of COVID-19, to know if there are any field studies that are going ahead that will be able to provide yourselves with further data to support the modelling and also to sort of understand what impact there has been to delays of programmes in the field. Thanks.
So I can answer for trachoma, and then I'll hand over to some of the others. So there's been a lot of discussion in trachoma about, particularly in these areas which are struggling to achieve the elimination as public health problem goals. And there's been a lot of discussion about whether those two simulations that I showed are actually two trials which have ethical clearance and are going on, can be rolled out from there. So I think there is a chance that there will be trials of those acceleration processes. My understanding is for most of the rest of the trachoma endemic world, they are being given their 2020 and their 2021 budget and treatments for trachoma for next year. So I believe that a lot of places are going to do 2 treatments next year or are planning to do so. So as you say, there'll be an opportunity to see the impact of that. And I hope there will be some surveys done before those rounds. Don't know if anybody has any other answers to that question.
For Onco, we have some collaborators in Ghana. I can't speak too much about it because it's not entirely my work, but there will be some data collection regarding changes in compliance and coverage during the outbreak. And also if we can get any data on how much bounce back there's been in serology and prevalence during that time.
Yes, if I can add. So we have a group of collaborators in Ghana, and they were funded by the African Research Network on NTDs. That was motivated by as Fiona mentioned, and we had already also met to discuss this, the possibility of conducting empirical field studies to collect some data partly to test the models and partly to quantify the impact. And yeah, so that hopefully that work is going to start in onchocercasis.
Thanks, everyone. Thanks for your responses. It's good to hear that there'll be further work. It would be great to sort of hear an update, maybe in a year or so's time, to hear more on that. Thank you.
Thanks, Fiona, for your question. Any more questions, please? Either unmute yourself or submit it through the chat.
Hello, there's a question from Chair Achungu from Cameroon.
Hi, hello.
Okay, madam, I'm very happy to be part of the webinar. I have a question. I live in Anglophone Cameroon, where civil war and COVID-19 has disrupted all the neglected tropical disease program, specifically schistosomiasis, onchocerciasis, podoconiosis, and even soil-transmitted hemigiasis. From the seminar, I've learned that we miss 1 year of, we have 1 year of disruption. It has a lot of impact on the neglected disease. My question now is, we are almost in 4 years of civil war and unrest in Anglophone Cameroon, where most of these neglected tropical diseases are present. What are we going to do now, please?
I think that's a fascinating question. I will pass off to the rest of the team as well. I think the modelling suggests that, you know, a year or two, these programs, exactly as you interpreted, may be all right, but you know, when you start to look to 4 years and beyond, the programs will have a big hill to climb. But one of the things that I think is interesting that will happen over the next year or so, which may be helpful to places such as you describe, is that if these trials of doing twice a year treatment actually achieve high coverage, or learn how to achieve high coverage on both those rounds, and you know, actually logistically successfully do two treatments in a year, then maybe there will be something to learn from that on how to accelerate a program. But I think it's going to be really challenging. So that's my comment really in response to you.
Okay, thank you very much.
Thank you for the question. Does anybody else have anything they wanted to say in response to that?
It's a question for the person who posed the question. So I understand that the conflict has been indeed quite protracted, but do you think there is any possibility or feasibility to conduct some vector control in some of these areas? I guess I'm thinking about onchocercasis, and I'm not thinking about larviciding necessarily. There are some trials in Uganda and also in Nigeria trying to remove the vegetation that acts as substrates for the cumulative vectors. On the one hand, it's possible to conduct this with social distancing, and it doesn't require an enormous team, and it seems highly effective in reducing biting rates. So in addition to treatment, if that were feasible, perhaps that could be tried. So I would like to hear your thoughts about the feasibility of doing that under the circumstances.
Thank you very much. Yes, we can do that, but the problem now is we have a situation where the two sides do not even allow scientists to go to the field. I'm talking, there are so many control programs, like the one headed by Professor Wanji on onchocerciasis in the Southwest, that has just stopped due to the fact that the two sides in conflict do not want to see scientists going to the field. They will continue to see what we can do, madam. Thank you for the advice. Thank you very much.
Thanks.
Thank you very much. I think I'm afraid we reached the end of our seminar. Thank you very much to all the speakers and to all the participants. You will receive a survey at the end, probably tomorrow, at the end of the end of the webinar. So we greatly appreciate if you could send us your feedback, because that will decide, you know, the next webinars that we are planning. So thank you very much for your participation, and I hope you enjoyed this first webinar.
Thank you very much.
Thank you too.
Thank you.
Thank you very much. Bye-bye.
Thank you. Thank you for organizing.
Thank you.
Thank you.
Thank you very much. It's very helpful.
Yeah, very helpful.